Start, sir.
A very good evening to all distinguished colleagues. I'm Dr. Sameer Muchala, heading the Medical Affairs at Zydus Healthcare Limited. At the outset, I'm sure you and your loved ones must be safe and healthy during these trying times. It gives us immense pleasure to invite each one of you today to our live webinar on evidence-based practice and COVID-19. We are currently reeling under the COVID pandemic, and we all know that these pandemics over the years have created a huge and significant and detrimental social and economic impact on humanity. COVID 19 has similarly affected our daily routine, may it be maintaining cleanliness or maintaining social distancing, etc. The field of medicine is also no different. Recently, telemedicine guidelines have been imparted by the government of India, and this is a glaring example how our practice is going to be in the coming days in this COVID era. To enlighten us more on this focused topic, we have with us Dr. K. Lakshman, who needs no introduction. It's my privilege to introduce him. He's consultant GI and laparoscopic surgeon at the Shanti Hospital and Research Center, Bangalore. His special interests include GI endoscopy, cancer, laparoscopic surgery. He is associate editor, Indian Journal of Surgery, faculty, GI surgery, RGUHS. He is a life trustee, Bangalore Medical College Development Trust, chairman, BMCDT, Infosys BMR. He is MRCS examiner for the Royal College of Surgeons of Glasgow, and he is also an examiner in surgery for DNB. May I welcome Dr. K. Lakshman and request him to take the academic proceedings ahead. Thank you very much.
Sameer, thank you very much for that introduction. I'll get my presentation going. I hope I'm audible and that you can see my presentation.
Yes.
Perfect. Good evening, ladies and gentlemen. It's a pleasure to be here. I would like to, at the outset, thank Zydus Healthcare for giving me this opportunity. As Sameer said, COVID-19 has upset our lives no end. The whole thing has been a roller coaster ride for all of us. And if you look at the aspects of life that it has impacted, there is absolutely not one little aspect of our life that is not touched by COVID-19. Social and economic aspects have been discussed at length. People have dissected it threadbare, the suffering, the human aspect of the suffering, the economic aspects that one can see and will be able to see. The projections, of course, are quite alarming at times. But one aspect that has not been shared in great length, at least with the lay public, there is a lot written about it in the medical circles, but at least in the papers, in the media, something that has not been shared at all is the impact COVID has had on scientific thinking and evidence-based practice. We've all been brought up to talk science for many, many decades, particularly so in the last 3 decades. So what I would like to focus on in this webinar is to try and refresh our minds about what evidence-based practice is. What are its limitations in the pre-COVID days? It's not that evidence-based medicine or practice has been universally praised and accepted. There have been limitations. You look at what those are. And the tremendous impact COVID-19 has had on the evidence-based practice, and how you and I, as medical practitioners, as doctors, how we can address them and see how we can minimize the negative impact of COVID-19 on evidence-based practice. Now let's look at what evidence-based practice or evidence-based medicine is. David Sackett in 1996 gave a big impetus to the concept of evidence-based practice. It is defined as the judicious use of current best evidence, and we'll learn more about what best evidence is as we go along. And very importantly, it's not just evidence. We need to integrate it with individual clinical expertise. That is important. Are we able to have the expertise to practice that particular evidence that we have? And last but not the least is the patient values. Does the patient really want what we are offering him? These are the three components of evidence-based practice. Now, if you look at what many of us, including me, do, particularly surgeons, I might add, I'm a surgeon myself, we have this gung-ho attitude about life, keep saying we have always done this, we have had no problems in our hands, we are experts, we have had 35 years experience, and this is what we have done, and this is what we believe is good, and so others must accept it. Well, it works very well in our hands. We may not be able to do something as well, but we can. Now, none of this is applicable as far as evidence-based practice is concerned. We need to have a scientific approach, and please note this. Ruskin, as long ago as 1853, clearly gave one definition of science, and that is to substitute facts for appearances and demonstrations for impressions. So we look at something and we come to a conclusion. We have some impressions. Many times it is prejudiced, and you cannot have that. You need to have data. You need to have facts to substantiate those impressions and appearances. If you look at the dictionary definition, I've taken this from two dictionaries. What transpires is that the fundamental principle of any scientific inquiry is a systematic study. You have to have a system. You cannot presume things. You have to demonstrate and prove to yourself and to the world that what you're saying has value, has scientific value through data. And please note that such an approach takes a lot of diligence, discipline, and time. And time is something that many of us will not have in periods of pandemic. If I say my trial takes 6 months, my vaccine trial takes 18 months, and then you wait until you get it, obviously, most people will say that that is not acceptable. But we will address this issue of lack of time and how we should deal with it as we go along. Edward Deming is an American who is known for his tremendous work in post-World War II Japan. He is known as the father of the Industrial Revolution in Japan, who brought in systems and methods which emphasized on accuracy. And he is supposed to have given this quote, "In God we trust, all others bring data." And most other leading personalities keep repeating this. And while this is perhaps a lot more popular in the engineering circles, I think it is equally important for us doctors to bear this in mind. Unless we have data, unless we have justification for what we have done, I do not think we should do our treatment based on appearances. It's not my intention to go into the detail of how evidence-based practice is carried out, but suffice it to say at this point that most of us will be looking at data through these three media. One of them is the original articles published. You can have reviews, systematic reviews, and evidence-based journal abstracts. Computerized decision support systems are there, but not in common use as of now. And if you look at the value of studies, this is the arrow that indicates the value of a study in terms of its scientific veracity. You will see from this a repetition of what I said earlier, that an expert opinion and an anecdotal experience is at the bottom of that scale. It has very little value. Retrospective studies have little impact in terms of science. Prospective studies are a little better, but the real workhorse of evidence-based practice is randomized controlled trials, preferably blinded. And as you cannot have large numbers in these trials, you can put the results of several of these RCTs, randomized controlled trials, in systematic reviews or meta-analysis, and that would be the basis for your scientific knowledge or evidence. Statistics is important, and most of us, including me, are very weak in this subject. And so I would not go into details of statistics, but I put this slide up to impress upon all of you that as doctors trying to practice evidence-based medicine, we need to have some idea of what statistics is. In that, you need to understand that there are certain caveats or certain areas where you can slip up. For example, if you have a paper that tells you relative risk reduction is very high, it is not very valuable. There must be an absolute risk reduction. So you need to look at that data, and just because somebody says the relative risk is reduced considerably, you cannot swallow that conclusion. Number needed to treat is another thing that you need to know, where for a given effect of a positive effect, for example, you may have to treat 30, 40, 50 patients. That would be less effective than if you need to treat 6 or 8 or 10 patients to get one positive result. The reason I put this up is to say that all of us must make some attempt to try and understand a little bit of statistics when we're talking about evidence-based practice. The other hallmark of evidence-based practice is peer review. Now, this is particularly important when you have so much information, what we commonly call fake news, so much information in social media, the print media, the visual media, where people are pushing their own ideas and their own thoughts and views, even quoting data, which may or may not be validated. So we must learn to look at sources of information where it is expressly mentioned that the information is peer reviewed. Peer review is a process where 3, 4, or 5 people in the same field who are considered experts will look at the data provided by the investigator. They give their views about where it could be improved, and once that kind of exchange of information and fine-tuning occurs, it then reaches the journal or the website. So please, when you look at information, before you agree or disagree or accept or not accept a given piece of information, I would urge every one of us to make sure that the source of that information is peer reviewed. Just to make it familiar for some of you who may not be aware of the stages of a clinical drug trial, I'll be very brief about this. Every drug which is used on humans has to go through several phases. The preclinical phase is in laboratory and in animals. Phase 1 is in healthy volunteers. Basically, it is designed to look at safety and dosage. Phase 2 is in a small number of patients, and it tries to look at the effectivity and toxicity of the medication. And phase 3 is the real workhorse, where at the end of the study of the patient, of the drug in a large number of patients, maybe 1,000, even more, then you're looking at effectivity and long-term usage and its side effects and its advantages. Now, if any governmental agency, before it approves a drug, has to have a positive end result from a phase 3 trial. Please remember this. Completed successful phase 3 trials have to be completed before a drug is approved by a government agency. Phase 4 is, of course, post-marketing, which looks at long-term safety. But you will find as we go along, even before COVID days, particularly after COVID, this whole process is being undermined, which essentially means that evidence-based practice is being undermined. So I repeat here just to stress the fact that you must have a completed phase 3 study. And some of the things that we normally miss out in all these scientific communications is to look at the end points critically. What was it that they studied? Where was the advantage shown? Was it really an increase in survival? Was it not? Was it an increase in quality of life? What was studied? What was it that was shown? And unless you have a logical, sensible, really useful endpoint, just because some drug does some good to the patient, one cannot accept it. That good must be substantial and it must be really improving the quality of life. You must also look at the adverse reactions and, very importantly, costs involved. Because these drug trials are quite expensive, very naturally companies would like to make good the amount of money they have spent, and so the cost will be high, particularly in the beginning. But then you need to know whether the good aspects or the good outcomes of these medications justify the costs involved, and that is a decision that a health professional has to make, and that's an important thing. Just to reiterate what we have said, the value of studies reflects in the level of evidence. So when you have a statement about the effectivity of a particular intervention, effectivity of a drug, for example, then you will say the level of evidence is 1, level of evidence is 5. These are the things that most consensus statements and guidelines will tell you. What it essentially means that if you have level of evidence 1, then there is a very high scientific value for that. And if you don't have studies, but you still have to do something, then the level keeps coming down. If you have evidence only from case series, they'll probably say it is level 4. And if that particular guideline is based on expert opinions, that will attract the lowest level of evidence, which is level 5. Essentially, what it means is that when you go towards level 1, the validity or the strength of this inference is high and the bias is low. Bias of the statement is low. When the level is low, the effectivity or scientific veracity is low because that statement will perhaps have a large bias from the investigator. Now, finally, once you have looked at all these aspects of a study, you have to look at whether your patients are similar to the patients studied in the paper, whether, as I said, the outcome is relevant. And very importantly, is your infrastructure and your training capable of giving the intervention that the paper recommended. So you understand that if you are a serious practitioner of evidence-based medicine, then there are several things that you have to do before you recommend something as a worthwhile intervention or a worthwhile medication to your patient. Now, even before COVID-19 days, what were the limitations of the EBP? Believe me, there were limitations. Everything was not hunky-dory. There were very many voices that said that EBM is perhaps not the greatest thing that happened to humankind. In a 2005 article, which was considered a landmark article, Ioannidis put across several aspects that he found was deficient in evidence-based practice. One of them, he said, it's frequently abused. It still happens to be eminence-based, couched in some data, which may or may not be very valuable, but leaders in medicine, because of their influence, push those data. And clinical research has become an advertising tool because drug companies usually sponsor or fund these studies, and obviously because of their influence with the funding, that they would influence the outcomes. Getting grants favors gamblers. Those people who make tall claims are generally favored by the funding agencies. Now, this may be a very strong and one extreme view about the negative aspects of evidence-based medicine or practice, but nevertheless, at least in small doses, in a small percentage of investigators, these points were indeed to some extent true. But on the other hand, there have been many papers, and I show one of those things here by Strauss in the BMJ, who clearly showed that many areas have shown improved outcomes after the practice of evidence-based medicine. Many areas in outcomes, treatments, survival, disease-free survival, improved quality of life, all those have been measured and proved to be useful. There has been a better application of knowledge, and there has been documented change in the physician behavior positively towards application of evidence-based medicine. So there are other voices, in fact, the majority of voices, which say that evidence-based practice has been good to humankind. Just a few more slides about where we are slipping. Remember, we are talking about pre-COVID days, where we were slipping in the application of evidence-based practice. The first and the foremost, many clinical applications, particularly in the field of chemotherapy and oncology treatment, have occurred after completion of phase 2 trial itself. And I think that is something we should all watch. You have to have a completed, successful phase 3 trial. And so before you recommend some treatment to a patient, you have to make sure that you have such an available phase 3 data. Endpoints are not clinically evaluated. I mentioned this briefly before. I'll tell you a little bit more about it. Suppose you have this expensive monoclonal antibody, which reduces the tumor size of a secondary in the liver from 10 centimeters to 5 centimeters, which means the size is halved with 6 months of treatment. It costs you about 1.5 lakhs per month. Okay, it sounds good on the face of it, but the patient is dead after 9 months anyway. And how does it matter whether he dies with a 10 centimeter tumor or a 5 centimeter tumor? He's dead anyway, with no increase in overall survival or disease-free survival. Quality of life is not measured. So if you understand this classic example, as a doctor, you must measure the endpoint critically before you recommend a given treatment. And always, particularly in oncology, many other intensive care and other kinds of treatments, there are validated quality of life scores, and one has to measure that before one says that a particular intervention, even surgery. So when a given intervention, be it a surgical procedure or an interventional radiology procedure, be it medication, most of us now expect that the quality of life is measured and that data given. In the last few minutes, let us look at what COVID has done to evidence-based practice. Truly a pandemic. I must say that India has been lucky in that we haven't had that kind of huge numbers and high mortality as Europe and United States has seen. But I must say that we are in early days yet. We were good in doing the lockdown. We're lifting the lockdown, and it is inevitable that we have to lift the lockdown. And if you look at the trend in the last 5-6 days, numbers are going up. We were perhaps having 3,000-4,000 cases per day at the most. Now we are having 7,000-8,000 cases a day. I remember for many days we were having a mortality of 100-120. The last week it was 150. But yesterday we saw a mortality of 260. So once the lockdown is eased, then it is very possible that we will have a kind of surge that we have not seen so far. So it is good for us to be mentally prepared for it. And obviously, the question foremost on all our minds is, what is the value of various recommendations that have been coming out from the Ministry of Health, from various bodies, from various organizations regarding their particular specialties? Now, one statement I can categorically make about the pandemic is that evidence-based practice has gone right out of the window. What has happened is that across the board, all sections of society, including medical professionals, have had a degree of panic. And once you panic, then the rational decision making will be adversely affected. And so we try to clutch at straws and do things which we would not otherwise do. And while I do not intend to go into great depths of various things, perhaps we can discuss it later on when we have some time for discussion. But what I can say is give you some brief, small examples as to why I make or I have made such a categorical and perhaps a drastic statement that evidence-based practice has gone out of the window in the COVID era. I feel that the reason for this is the impact of COVID on the economic, social, and political aspects of our life. Now, let us look at how each of these has an impact. I'll show you some evidence-based or peer-reviewed articles and some newspaper articles so that you have a mix of what is the kind of information that's going on. Now, there is very little doubt that isolation, quarantine, and social distancing have had a major role or play a major role in limiting the spread of the disease. But you have many people who question this very basic thing. It started with Sweden, for example, which had a very unique approach and said, while we will not enforce quarantine, we will tell you that if you keep a social distance, you'll be better off. Their population is so small, their awareness and their approach to life is so different from perhaps ours, for example, that even though the government didn't impose distancing, they distanced themselves. Most people chose to stay at home. Britain, for example, thought it would take a leaf out of Sweden's book. And in the initial phase, Boris Johnson, the Prime Minister, said that, yeah, we will not have quarantine, let's have immunity, herd immunity. And they paid a huge price because the Britons were not as disciplined as the Swedes in maintaining social distancing. And so you found that very quickly it spread, and then a week or 10 days later, they clamped down on quarantine. By that time, it was too late. Today, 6 weeks on, Britain has the highest mortality in Europe, 37,000 people for such a small population. Think of it, India has 4,500 deaths for our huge population, 37,000 deaths in the UK after this. So even a very well-established phenomenon like quarantine and social distancing was questioned. UN again made very clear statements about how we should be careful about lifting lockdowns. And what happened? Everybody questions WHO's wisdom. COVID-19 lockdown has been released in different parts of the world in the most chaotic manner. Somebody, in spite of surging cases, lockdown is lifted. Somebody, in spite of cases being very few, continue with the lockdowns. And so if people sat together and thought about it logically and in an evidence-based manner, then this chaos wouldn't have prevailed. And some people even say the reopening dilemma that saving lives versus saving economy is not an argument at all. It has to be. It has to be an argument, and both economists and medical personnel have to sit together and come to a consensus. But instead of that, they're at loggerheads. People sitting in their isolated compartments say that you have to save lives and have a complete lockdown. Whereas economists say, look, if you If you lock down, there is no industry, there is no income. Instead of dying of the virus, you will die of starvation. Now, both are extreme positions. There is some middle path, and I see very few areas where this middle path is being discussed and projected and decisions taken logically. And nothing is more glaring in our own country than this, an economic aspect which makes practically fun of distancing. I know that the aviation industry is reeling under a huge loss, but then once the skies have opened up, the government itself permits our airlines to fill all the seats because they need to make money. But then that again will have a negative impact on the distancing and on the spread of the disease. And you needed to have the Supreme Court to come into it. I cannot understand why the court has to deal with these matters at all. Coming closer to the medication, apart from the, we've just moved on from the social distancing and quarantine, this huge controversy about hydroxychloroquine and remdesivir. In fact, you have a French biologist and a virologist pushing hydroxychloroquine as the panacea. And you find Fauci and his group pushing remdesivir as the drug of choice. And in fact, people, instead of working together and trying to see how both can be used, perhaps, try to get the data as soon as possible, how both can be used either together or in different groups of people where each of them may be more useful. As somebody said it, they are behaving like sports rivals on the sporting field. Come to the point of masks. You have seen so much good data on what kind of mask does what. I won't go into the details of it. What is the role of a surgical mask? What is the role of a 3-layered mask? What is the role of an N95 mask? There is enough scientific data. But do we have anybody saying, look, this is where this has to be used? True, the medical bodies, for example, the Association of Surgeons of India, for example, they have given very good guidelines about what should be worn where. But if you look at the lay press in terms of educating the lay public, we have absolutely no clear direction. And most people run around thinking that a mask protects them from getting the virus. Far from the truth. You use a mask to make sure that you don't shed the virus and put it into the air as much as possible. That is also extremely important because that will reduce the viral load in the air and reduce the spread. But then that kind of scientific information must reach the public. And I needn't talk about the gentleman shown in this picture. This is him in a car manufacturing unit. In fact, at the height of all the recommendations that people should wear a mask, both by the WHO and his own medical team, he goes out to a mask manufacturing unit, a Levi's factory, where masks were manufactured on a large scale, and makes a statement to say that I don't need to wear a mask. I don't need to wear a mask. Now, this is the kind of attitude that people have, and the political impact is huge. Instead of all of us getting together and working to see how we can find solutions, we are throwing allegations at each other, and the already severe economic impact will be made much worse because of the political handling of the whole situation. So how can we address these issues? I didn't want to bombard you with a lot of data about all this, which I had, but I gave you the overview of the kind of problems that we have created for ourselves in these difficult times. Now, how can we address these issues? I think there must be a complete transparency of data that is lacking. All the data that is generated from hundreds of studies that are going on must be available in public domain. It's a tall ask, probably will never be done, but that's what improves the credibility of the investigating agencies and the trust that people will have in those data. and the selective reporting of success and a suppression of the failures in terms of the data being made public must stop. This happens all the time. It used to happen before COVID, and I think it is happening even more now, and that should stop. And we should have better teaching of evidence-based practice, both to our medical fraternity and to the lay public, if not in that depth, but at least they must know about peer review, about the validity of data, the importance of negative data, and the importance of statistical significance, false negative rates, for example. If somebody does a COVID test and it's negative, it doesn't mean to say that you're negative. No, there's a 20%, minimum 20% false negative rate. And people must be aware of that. And we must have a better dissemination of scientific knowledge, above all by clinical leaders. I put it in bold and I underlined it. Today, knowledge is disseminated on social media, on visual and print media by lay people and perhaps journalists. And I do not see clinical leaders taking a lead, taking a prominent role in the dissemination. They must work towards sifting through knowledge available. There is a lot of confusing data available. The clinical clinicians, the healthcare personnel must make some sense of that data, and then they must disseminate the knowledge to their own colleagues in the healthcare field and the lay public. Only then we can reduce the confusion and have a more scientific kind of approach to this problem. And I reiterate this here, that there are various attempts that are being made to say that there is a lot of fake news that is running around, but these kinds of well-intentioned warnings by the authorities seem to have had no effect, unfortunately. And I honestly don't know what else they can do. They can warn you, the government can warn you, but as individuals, we must know what is the correct approach to getting data, and we should try and make sure that health professionals are taking the forefront in this dissemination and not the social media. Are health professionals above board? I keep saying this, that health professionals must take the lead, but sadly, there are areas where even health professionals are looking perhaps for a degree of publicity, and they want to figure in the papers, in the media, with really no substantial achievements. You know, there is some huge breakthrough, I can understand. Look at this news item. Please note that ICMR has stopped the plasma trial, but there's a big news item on April 22nd that one of the hospitals, I won't mention the name, I have covered the name there, they got permission from the authorities to commence a phase 2 trial, convalescent plasma. Okay, it's a very beginning of a scientific trial, and that makes headlines in a paper, as if that hospital is going to give you a cure for COVID from the very next day. Now, this is the, you know, when you keep saying that we must empower the health professionals, unless we self-regulate and unless we are really concerned only about science and nothing else, then we will also be doing a disservice to society. And less said about this, the better. Hydroxychloroquine, with or without azithromycin, has been shown to be not useful in the treatment of COVID-19 patients. In fact, it caused a higher mortality, unable to confirm the benefit. Of course, even this has been questioned in the subsequent days, but by and large, you will find that hydroxychloroquine, about which so much noise is made, perhaps is not useful in the treatment. But while lay people do not understand this, we must understand that perhaps there is some value, even though the data is not completely mature, perhaps there is some value in hydroxychloroquine. And as far as prophylaxis of healthcare workers, frontline healthcare workers is concerned, and ICMR in fact has recommended prophylaxis for healthcare workers. So when you read a paper, we need to know, is it being used as treatment? Is it being used for prophylaxis? What is the dosage? What is the data available for it? So in two papers that ICMR has quoted with 300-400 in each of those papers, some role has been shown for prophylaxis. The side effects are not bad. And so if you do not have an underlying cardiovascular disease or an arrhythmia or an allergy to chloroquine, and you are a healthcare professional, there is some value in taking hydroxychloroquine as prophylaxis. So professionals must take the lead. Taking the lead is not enough. They must be completely honest. They must show integrity. And very importantly, there should be no commercial consideration in what we say and what we do. If we do that, then there will be some hope for us to face this huge pandemic and its terrible consequences. Thank you very much for your patient listening.
Thank you, Dr. Lakshman. I think it was a really crisp oration, and the points were clear to the delegates. What we are going through in the current era, which is going to stay for some time, it's really not going to go away. So these are all practical challenges that the medical fraternity are going to face. I have a lot of questions on the comment link.
Yeah.
I will be able to go through few of them.
Sure, thank you.
The first question is a very challenging one because it says how to translate theory to practice. And I'll read out the question for you. How relevant to clinical practice is the concept of number needed to treat, which is usually seen in published literature?
Yeah. I think that is the crux of the matter. Now, if you have an individual and you have to make a decision for that individual, you may say that he may fall in that, suppose the number needed to treat is 30, which essentially means that if you give it to 30 people, one of them will get the benefit. Now, you may argue that that one person who's sitting in front of you would be the person who would benefit. But I would say that please think it's more likely that he's among the other 29 who will not benefit. And that is a very simple, to my mind, a simple decision, and that you have to look at the number needed to treat. You have to look at the percentage advantage of certain things. For example, a similar approach is, if you have a chemotherapeutic drug which has a 30% response rate, okay, and I would say I would look at 70% non-response rate. Why would I spend lakhs of rupees on that medication for that response rate? So you may say, look, how can you deny that person? He should know. I agree with you on that. So the minimum you can do is be completely honest to that particular patient and say, look, NNT, number needed to treat, is 30. I don't know which group you belong to, but if I give it to, what it means is that if I give it to 30 people, 1% benefits. Now for that benefit, that chance, if you are prepared to pay the kind of money that you have to pay for this intervention, you go ahead. If he says, yes, I want it, I would give it to him. Today, we are, apart from evidence-based practice, we are in the era of shared decision-making. The paternalistic view where the doctor was telling the patient what to do is gone. So we need to take him into confidence and have a chat. It takes time to discuss it, but we do discuss it when we suggest something, and if he wants it, you give it.
Correct. The next question is from Dr. Nishant, and he says, please comment on the COVID status affecting morbidity post-surgery rather than it being seen as a doctor trying to protect himself and his team.
Yeah, it's a very good comment that he has to make. Because it was a general talk, I didn't talk too much about surgery, even though I'm a surgeon and I'm very well aware of this. It is known that in the COVID era, that the morbidity of non-COVID related operations, like your gallbladder operation or hernia operation, is much higher than in the pre-COVID era. For example, if you had a 5% complication with a gallbladder surgery, 3% complication, today it is known to be 27%. And most of those complications are chest related, not the operation per se, not the gallbladder operation per se. And that comes because of asymptomatic patients. They're vulnerable, their immunity is low, and they're already suffering from the virus, which you cannot detect sometimes. And so the morbidity is higher. And so what, at the same time, you cannot not treat them. They may have morbidity from the condition itself. If you have an empyema gallbladder, a stone stuck in the bile duct, the morbidity of sepsis is much higher. So we need to balance this view, check the COVID, the government. I saw yesterday in a newspaper, item that government is now allowing COVID testing for patients who are undergoing surgery. Until very recently, that was not actually allowed. But now that the testing facilities are more and the hospitals are opened up, I would certainly recommend that all patients undergoing any kind of elective surgery must have COVID tested. And if they're COVID positive, and if their underlying condition allows them to wait 3 to 4 weeks, I think you should not undertake an elective operation.
This is an OPD based question. Sir, can you please comment on the efficacy of using gloves in OPD?
Okay, this is controversial. When we started using gloves in the OPD, when we started our outpatients 2 weeks ago, the government lifted the lockdown and said hospitals can work. We should have an OPD. So we used the basic PPE, which is a gown, a cap, an N95 mask, and a visor, and gloves. And we were cleaning the gloves itself, because you cannot take out a sterile glove, for example, which covers you completely after every patient. If you see 10, 15 patients, you can't keep throwing out one. It's very expensive. And so you can't keep throwing out. So we were cleaning the glove itself with our alcohol-based solution. And I was a little uncomfortable with it. And I saw a report which said that if you clean the glove, it doesn't work. Either you don't wear gloves, or you throw out the gloves after every single use. The reason is that you may have small holes which you do not recognize, and there may be a gap between the glove and the sleeve of your gown, which will again not get cleaned when you wash the glove with the alcohol-based solution. And so for the last 5 days after I saw that report, I have stopped wearing a glove. Instead, I have everything else except the glove, and I wash my hands after every patient or fomite contact. Wherever I touch something, I wash my hands. Again do the next thing. So that is about the glove, and I don't think the last word is said about it so far.
This is a technical question. In the current COVID era, are there any risks of creation of pneumoperitoneum during a lap cholecystectomy?
See, again, that's a bit controversial, but there is no doubt that aerosolization occurs with laparoscopic surgery. Very little doubt about it. There are many papers to that effect, and many of us do not have the equipment to suck out the pneumoperitoneum in a closed circuit. Even if you suck it out from the abdominal cavity, it will go into the operation theater air. Ideally, it must be sucked out of the operation theater to outside to the environmental air, but very, very few centers, I think, have it in this country. And so what we are now doing is minimizing. Our technique is such that we do not let air out from the abdominal cavity. Earlier, if we wanted to let the smoke out, for example, we would just open the valve on one of our cannula and everything would come out into the OT. We don't do that anymore. We formally suck it out, but we are aware that even if we suck it out, it will probably go somewhere else into the operation theater. So we are depending on the fact that the patient is COVID negative, because we do a test before the surgery. We are aware that there is 20% false negative rate. To that extent, there is a degree of exposure. Even though we don't use a full PPE for COVID negative patients, we do have partial PPE for all patients. And so to that extent, I think the healthcare workers are protecting themselves.
This is an interesting question. Is evidence-based medicine already a part of medical education curriculum? If not, are there any steps taken by the government till date to this effect?
Yeah, this is an excellent question. I think I have the very fact that I agreed to do the webinar. I must say, you probably realize I was a little reluctant. There are so many webinars going around. I didn't want to add to it, but then I said, I would talk about it because evidence-based medicine is one of my favorites. Uh, the answer to that question is there is no formal education for evidence-based medicine in our curriculum. I think the NCI is trying to put it in, and individual pockets and institutions are using this. And I must say, from the Karnataka state chapter of ASI, of which I'm a member, we ourselves have workshops on evidence-based surgery. No, evidence-based surgery, evidence-based practice, evidence-based medicine, they're all the same. The principles are the same. So we have one-day workshops, and we are in the process of having, again, thanks to COVID, webinars, regular webinars under the umbrella of ASI Karnataka for evidence-based practice. And people who are interested may kindly keep an eye out for it, and I'm sure something will come to fruition in the next 3 to 4 weeks. These webinars will be open to everybody, so they can learn from it. Even though there is a stress on surgical practice, it will be equally applicable to all branches of medical practice, and I think it will be useful. But yes, the point is taken that we must inculcate evidence-based principles from the undergraduate level. It's not happening at the undergraduate level. It is minimal at the postgraduate level. And so something must be done on a war footing about this.
There's a question, a highly reactive question immediately from Dr. Srikanth. What is partial PPE?
Partial PPE is what I have defined as what I told you earlier for my outpatient care. We use a gown over our scrubs. You know, as soon as we get into the hospital, we don't wear our street clothes. We go and change to scrubs. We then wear a gown over it. It's not sterile, but it's another layer of protection. And we have a cap, we have an N95 mask and a face shield to prevent the aerosol from reaching our noses. This is, and foot cover when we do it. And when we do an endoscopy, we switch over to a full PPE, which is, in addition to this, there will be a hood and a plastic apron underneath your gown. And the same thing is used in the operation theater for a full PPE. The only difference is that the PPE, full PPE used in the operation theater is sterile. In an endoscopy room, it is clean, but not necessarily. I mean, we get a sterile pack, but we don't use the same precautions that we use in the operation theater to remain sterile. We may touch something, because for an endoscopy, we're not looking at full sterility.
Next one is a tough one. Clinicians may exhibit some reluctance to adopt evidence-based medicine as it may challenge their autonomy or institutional hierarchy. What are your views on this?
It's a good one. I really think that if you are practicing evidence-based medicine, your eminence increases. And that is the magic of hierarchy, in my view. We are today living in a flat world, honestly. You know, as Thomas Friedman talked about economic flatness, there is also a flatness in the way we run our departments. For example, in our own department, I have never been, in fact, I'm very happy if somebody questions my actions. It keeps me on my toes. Either I have to justify my action or I have to change my action so that we are going by evidence-based medicine. I don't think my eminence as a senior is in any way compromised because of this approach. In fact, the students will be very happy, I think. And that's been my practical experience also. So hierarchy doesn't matter at all. You need to have your knowledge. You need to practice evidence-based medicine. You've got to, you must be an example that others follow, and the rest of it will fall in place.
Manjari from Mumbai has a question. With protective equipments becoming mandatory, maintenance cost of a setup escalates. How does a small nursing home cope up with this, bearing in mind perception of a patient that medical cost would be reasonable in a smaller setup as compared to a corporate hospital?
Yes. I work in a small hospital. It's not a corporate hospital, but it's not complete truth. It's like a corporate hospital. I work in two centers. One of them is an ordinary small nursing home. The other one is a semi-corporate setup. Both places, I said this because I do not differentiate anything between the two places, because our safety, safety of our staff and the safety of our patients are paramount. Dr. Manjari is completely right. There is an escalation of cost, and we tell every patient that once you come into surgery, your costs go up by something like 6 to 10,000 rupees for the operation just because of the COVID situation. We tell them, and so far they have accepted that, and we are doing operations. The only thing is that you cannot compromise on safety. You may lose some patients. Some patients may misconstrue you. That is also possible. But there's nothing more you can do than being honest and transparent.
Okay, you got an immediate appreciation from Dr. Prashant saying that the answers are just wonderful to all the questions posted.
Thank
So
you.
we have few questions. I think we can just take them.
Yeah.
Dr. Yala Gachin from Hubli.
Yes.
The question: any specific ways for scope sterilization for the next patient?
No, there isn't anything specific, because most of these viruses are, they die with the standard procedures. These standard procedures that we I won't go into the details, but we use. I mean, I'm sure I know Dr. Elagachil is a professor. I know him well. So the standard procedures we all adopt actually are bactericidal. They kill bacteria, and they're even designed to kill tubercular bacteria and even some spores. That is the standard. So all viruses across the board, we learned it right from the HIV days. Across the board, all viruses are a lot more vulnerable than bacteria. And so standard procedures are good enough. The problem with COVID is its existence in the air. And that's why the recommendation that there must be a minimum of 2 hours gap between cases. So if you do a COVID patient for whatever, for an emergency or whatever, do not do another case, not because of the instruments. 20-minute flash sterilization or whatever else that we use between cases is good enough. But the air cannot be clean, and so you need to give a gap of 2 hours between cases.
Dr. Naz Sheikh from Hosapete has a question. Initially, we were asked to avoid surgery, manage conservatively, and if possible, absolutely essential, do open surgery. Does this recommendation stand today also as things have changed?
Yeah, very good question. It doesn't. In fact, going by the recommendations of various bodies, we did the same thing. We had a patient with empyema gallbladder, for example, in late March. Normally, I would have, she's an ill patient, elderly, I would have normally operated on her. But because of the recommendation at that stage, we did a percutaneous cholecystostomy, ultrasound guided. We put a tube into that infected gallbladder, let the pus out, and she recovered. And we did her gallbladder just last week, I think, that's 10 days ago or something like that. So that was the initial recommendation. For the last 2 weeks, people, government, the Ministry of Health and various other authorities have allowed normal functioning of hospitals with precautions. And so for the last 2 weeks, we have started doing work like the way we were doing with the precautions. But what is interesting is that perhaps like the Swedes, we must give credit to our population also. Our outpatient attendance has come down at least 40%, post-COVID, because patients themselves are afraid to go to hospitals. They don't have the confidence, and it's quite right. They're going into a place which may be full of COVID, without our knowledge. So I think it's very wise. And so from my side, at a selfish point of view, my outpatients are more interesting, because the average patient with small complaints who's worried about a little nickel here and nickel there is not there. Patients who come are limited in number, but by and large, they have a real surgical problem in my outpatients. And so I think we're serving the population the way we should.
Naz again has a question. Allowing the CO2 out into a sodium hypochlorite solution and an HEPA filter, will it be all right during laparoscopic surgery?
Yes, I think it will be theoretically all right. I have not seen any data about it, but I have seen messages in the WhatsApp groups and other groups where people are doing it. I'm not averse to it. I think it's a good idea, and it can be done. It certainly doesn't do any harm. But I would again say, please don't take any of these things, including hydroxychloroquine prophylaxis, don't take it as a foolproof method. So you need to continue with your personal protection that you normally use.
Uh, CO2 insufflation pressures are supposed to be kept to a minimum, keeping COVID in mind. What is the minimum pressure which can facilitate laparoscopic surgery?
I'm not practicing it, to be honest, but one with some experience, one can easily do a laparoscopic surgery with 10 millimeters of mercury. I normally use 14.
Okay.
I'm continuing to use 14 because I do not think that this reduction will reduce the viral load in a big way. The only practical change, I'm repeating what I said, is that we don't let the gas out into the air. We suck it out, and that way I hope to minimize the ill effects of aerosolization. But yes, on other occasions, because of cardiovascular instability, for example, I have done big laparoscopic operations with 10 millimeters of mercury.
Dr. R.K. Srivastava from Bhandravati has a question. Ultraviolet ray lamps to sterilize OT and endoscopy room, any role?
I honestly don't know. I can't answer that with any surety because I have not seen the effect of ultraviolet rays on COVID per se. So I'll have to look it up. I can't tell you.
Okay. Another technical question which is there. It says that, maybe not related to COVID, it says that is varus needle insertion still an mandatory initial procedure, or with adequate abdominal pull, we can straight away go ahead with trocar cannula insertion?
There are papers, there are practitioners who do a direct trocar insertion. I've never done it. Many gynecologists I know do it, and I know at least one paper which was presented by Command Hospital in Bangalore some years ago, which showed that it was perfectly safe. It can be done, provided there's one big rider to that the patient should not have had any previous surgery and should not have had a history of intra-abdominal infections like tuberculosis and things like that.
I think we can take one final question.
Okay.
Is fundus first method, can fundus first method be the routine procedure, or there are some set guidelines only, like difficult Calot's triangle, to go through fundus first?
It's your choice. I mean, fundus first is never easy. I mean, I've done fundus first many times, but I would never look at it as a routine procedure, because however careful you are in removing the fundus, you will end up with bleeding from the liver bed, and it can flow down onto your callus and make visualization difficult. So while it can be done, I would not recommend it. I would still do callus first and do fundus first only if I'm forced to because of a difficult callus. And my personal practice is to do a subtotal cholecystectomy rather than a fundus first.
Great. So I think we had a great oration. Before I give the vote of thanks, you would like to have the few closing remarks from your end.
Yeah, thank you. I enjoyed it thoroughly, and I'm very happy that we had a good discussion and there were quite a few questions. Samir, I would like to thank you and for your excellent moderation. Thank your organization for giving me this opportunity. And I hope that one of the things that COVID has done is to have such interactions again. And I hope that we'll have more of this on interesting topics in the days and months to come. Thank you very much.
Thank you, Dr. R.K. Lakshman, for an excellent deliberation on evidence-based medicine, especially keeping COVID-19 in mind. Your medium of delivery was just lucid, and the questions were answered in an excellent way. Population of message, I think, was perfect. I already shared with you. A couple of delegates have already appreciated. I think it's the need of the hour to be aware of the changing dynamics of clinical practice, considering COVID-19 is going to be staying with us in the recent future. It's not going to go off. I am happy to share from Pan India, we had 512 doctors who have witnessed today's webinar. I thank you all for sparing your precious time, that too on a Saturday evening. And thank you for helping and supporting our Indian COVID patients during these real trying times. I request you all to stay safe, stay healthy, and may God bless all of us. Thank you very much.
Thank
and
you
have a
and
great
good
weekend.
night. Thank you.
Thank you. Okay, done.
I'm ending, sir.